always like to have for the live cases as well as for the renal denervations. We have Denisa and Nikki, and Freddie is our tech for the day. So I think without any further haste, so that we can make sure we get back to room 2 to show the IVUS of the final of that left main case. We'll begin with our case presentation. Shalini, if you could, please.
Yeah. So our patient today is a 69 years old female who presented to the clinic with resistant hypertension despite being compliant with multiple antihypertensive medications. The
There's
blood
a right
pressure,
patient that multiple medicines and pressure is still very high.
yeah.
Oh.
The blood pressure recordings at home routinely runs around 110 to 200 of systolic and 100 to 110 of diastolic. The past medical history is notable for hyperlipidemia. She also has coronary artery disease with angioplasty and stenting to circumflex in 2019. She also has PAD. She's a former smoker. In terms of antihypertensive medications, she's on a good dose of amlodipine 10 milligrams once daily, a Benicar 40 mg once daily, Toprol 50 milligrams once daily, along with the diuretic chlorthalidone 50 milligrams once daily, along with an alpha blocker and spironolactone. She's also on Plavix and Lipitor. So the preliminary diagnostics to exclude secondary hypertension, which includes plasma metanephrines and serum aldosterones, were within the normal limits. The basic metabolic panel, including creatinine, electrolytes, thyroid function test, everything were pretty much in the normal range. The arterial duplex of the renal arteries showed no evidence of stenosis in the right and the left renal arteries. There's no evidence of fibromuscular dysplasia from the renal arterial duplex. So with this briefing of clinical presentation, I'll let Dr. Sharma to
Yeah, no, that's a great explanation of our case so far. So before we begin, I just want to let everyone see kind of how we started. Again, this is a a middle-aged woman. She's on multiple medications, 4 or 5 on very, very high doses. And, we kind of have run into a point where we don't have any more adequate oral antihypertensive therapy that we can really use to help control her blood pressure. So, this device itself that we're going to be illustrating the use today is one that we use very, very often here. And this is nearly approved as well in the US. I understand that in India, the utilization of these other new devices is a slow introduction, but there's a lot of really great data to support its use. So we'll begin by showing some of the angiograms. Then I want Shalini to go over again kind of more information about the device itself and the data that was shown. I think what would be really useful is to kind of begin by maybe just discussing first, for the panel, like, what would you do in India right now? You have somebody on multiple medications who doesn't really have, any further room to add on, or will you just keep on adding until you think that eventually there's going to be some adequate, control of the blood pressure?
A lot of things to be done. Initially, what is the major problem in the patients with resistant hypertension is basically the patient compliance is not there. Patient may be telling that they're taking. So we have to analyze the compliance properly and then analyze if it is again resistant, then we have to go for analysis of any secondary hypertension cause. If there is a hypertension cause, then you have to treat it. Otherwise, RDN is the therapy here.
Yeah, no, that's absolutely correct. Shall
No,
I give Andy that?
I think I agree with you. The biggest reason is compliance, and that's why here me, Raman, PK, and everybody in our practice believe in like ambulatory blood pressure, which not only records the blood pressure in the clinic when they come in, but also at a home. So that will give us a very good idea of how the blood pressure is behaving, and with compliance right there. So I think that's one of the important parameters. And then eventually, if everything fails, like you said, this is now the new therapy of choice, which Raman and we are going to show and see how it works. And we've seen great results in the initial patients, and also based on the data is very convincing that it is one of the now good therapies in management of long-term resistant hypertension.
Yeah, and I will say, as you approach 4 or 5, 6, sometimes 7 medications, just that in and of itself makes compliance quite challenging. And I think this therapy is one that is a very great introduction to the realm of antihypertensive treatment, and can help simplify some of these regimens for some patients, and in some cases even help reduce the pure number of antihypertensive medications that are going to be needed. So the device we're going to be using today is the Medtronic Simplicity RDN device. Is it available right now in India?
Yes.
Is it used or just not very often?
Not very often, but it is used in India for the
Okay.
last 2-3 years.
Good. Yeah. So I mean, so we've only recently been able to start to use it much more often. It's mainly because of the not just the patient selection, but also making sure that we have the insurances also all on board. I think this would be a good time just to go for a quick review of the literature to kind of show why this is a reasonable treatment plan for these patients. So I think Shalini is going to go over the recent studies to illustrate its utility in this population.
Yeah.
Can we have the slides?
Can we have the slides, please?
I can see the BP is 150 only now.
Yeah, so I want to get to that. This is the patient, for this procedure, it does require a lot of sedation. So these patients, I'm going to talk about our protocol right now, about how we handle these patients on the table. So yes, right now the pressures are in the 150s, but she's had multiple rounds of sedatives while she's already sitting here on the table in preparation for the procedure.
Yeah, I think it's just a deceptive decrease in blood pressure because of sedation. But like in the office, it's been consistently like 170s to 190s systolic based on the 6 medications she's taking. So.
Yeah. So Shalini?
So let me give an overview of renal denervation. Renal denervation, as we all know, is a minimally invasive endovascular procedure to treat the sympathetic nerves around renal arteries. And renal denervation has been shown in multiple clinical trials, including sham-controlled randomized trial, to produce meaningful short-term reduction in blood pressure and as well as a long-term durability in the global Simplicity registry. Moving ahead, this slide shows the time frame of renal denervation trials over the last 1 decade, starting from Simplicity hypertension to spiral hypertension on, spiral hypertension off med to radiance and target trials. So moving on with the spiral clinical study, which demonstrated the efficiency of the Simplicity spiral multi-electrode, which is the second generation radio frequency ablation catheter for renal denervation. So renal denervation, when compared with the sham cohort, has
Actually, can you show the case directly? And we are actually inclined to see the case, please.
Okay.
We're running behind the schedule. That is why. Can you show the case?
Yeah, for sure. I just it's important to highlight the role for RDN in this population. But I think Shalini, and it's important to do mention the fact that there's a lot of sustained benefit that we see in these patients. But we'll talk about kind of our protocol specifically. I'm sure you can hear in the background our patient snoozing away. That's because the denervation portion itself, it can be quite uncomfortable for the patients. So we make sure that they are very, very well sedated. We like to have these patients even before they come into the room to get a dose of some medication, whether it's some Valium on the outside or whatever it may be, to help prepare them for this. The first step that we do is that we go with the 6 French system. Typically we go with the right, but she has a big calcific nodule on the right, so we went with the left in this case. And to begin with a non-selective pigtail angiogram, which we can see over here, to identify both of the renal arteries, the right and left. Now, can we share this screen? You guys can see that correctly? Good. So the main things about this device, we can zoom in to what Vishal is holding here, and we can show the actual device.
So this is the
There's a question from the panel.
Yes.
What sedation you have given to the patient?
So we use a combination of fentanyl and Versed, and we use it very liberally, especially during the times immediately preceding the actual ablation portion. If we found that when the patients are not adequately sedated, they really move around in a lot of pain. The good thing is that with the medications, there is a good amnestic property, so they forget it. The problem is not so much the patient discomfort, because we can work our way around that, but the patient movement, when they take a big breath, actually dislodges the actual catheter itself within the renal artery, and that can result in a treatment failure in a particular segment. So we'll be able to go
Right.
over that in a little bit more detail.
Yeah, I think it's important, like Raman said, sedation is a crucial part because the patients do feel the pain in their back and they wake up. And like you said, waking up can dislodge the catheter. But anyway, showing you the catheter to save time, the whole idea was spiral simplicity, the way this is spiral. This is the end of the catheter, which has 4 emitters, which we're going to show you on the screen as well as on the panel, where all the radio frequency happens. The mechanism of action is radio frequency ablation. The idea is to generate heat, which eventually affects the nerves which are circumferential around the renal artery, thereby causing their burning, so to say, of radio frequency and decreasing a sympathetic return. So here you can see that's how the catheter will be. Let me show you. Yeah, better. Sorry. So that's how the catheter will be inside, but because we cannot deliver it this way, it has to be straight line. It has a nice introducer sheath right here, which actually straightens it out, and you can put it on the wire, which I'm going to put for Raman. So we wire our renal arteries, and like Raman talked about, it's very important to have a non-selective angiogram because you want to evaluate / rule out accessory renal arteries, because if you have to have a full, comprehensive, complete treatment, then we have to go after the bigger arteries as well.
Yeah.
Because like we'll talk about, the sizing is an important characteristic in these patients with the size of the artery between 3 and 8. So anything less than 3 millimeters or anything less than more than 8 millimeters is actually excludes you from using this device effectively if you want to.
Exactly. That's the importance of this pigtail angiogram is really just, as Vishal was saying, was to make sure that there are no accessory vessels that need to also be ablated, because if there is a sizable accessory vessel that is not adequately ablated, then that should be considered as an incomplete therapy.
So we do take a selective. We have a 6 French guide, like we're talking about. So this is a rapid exchange mechanism. So we take shorter guide, and we take a regular coronary wire. Here, in this case, we have a Grand Slam, which gives us good support. So we selectively engage, and we got selective angiograms on both sides to make sure everything's okay, which Raman got. And then Raman, he wired here with the Grand Slam wire.
So
and
it's, the extra support is absolutely necessary. Unfortunately, your workhorse wires don't really have the support that's going to be needed.
Right.
So we use the Asahi Grand Slam here. The other places also use the Boston Scientific, the Forte, or the Choice extra support. But an extra support is going to be needed because as the catheter itself is being delivered across the wire, it wants to resume its natural shape. So if you have a softer wire, it's going to do so and buckle on the actual wire, and you'll lose whatever purchase you may have. So right now, if we can see in the guide, we see a total of 5 radio-opaque dots. The most distal, the smallest of the 4, is the tip of the catheter. The next 4 are the actual radio emitters. All right, and this is going to be important in terms of our angiogram. And this is our right renal artery angiogram. And in these, we see the main renal artery, and then we see 3 separate distal branches past the bifurcation. We see the most superior one, which is feeding the superior lobe. The most inferior branch is actually feeding the middle lobe, and then the middle branch is feeding the inferior lobe. The way how we like to do this is, again, we want to make sure that all the vessels that are between 3 and 8 millimeters are adequately treated, and there should not be any ablation near any of the bifurcations. So if just by rough estimating here, you can see the outline of the renal parenchyma, which is right past the first bifurcation. There really should not be any ablation happening beyond this shadow, because then you can get too distal, causing more renal damage. So the idea would be that we selectively engage the most inferior branch, the middle branch, and the upper branch, which may be a little bit too small, but we'll try.
Right.
And then we will just do freeze frames pulling back to do the full cycle. And when we're ready to go, we'll be able to give a little up.
Yeah, and the idea is to do it distal to proximal. So like Raman talked about, we start from the most distal end, and here you can see those 4 markers right there, which are the real emitters where all the action happens.
You see
and
how
a slight dot,
how it takes that shape again. Now you see a good position, and now we can zoom in on the control. We should get ready with some more sedation.
Yeah.
So now we see here.
Hold on, let me get the control.
There
Yeah.
it is.
So I don't know if you can see the control. it's actually illuminates like fluorescent green lights. I don't think it's showing, but there are like 4 buttons, each for each of those emitters right on the catheter. So the good point about this whole device is you can actually control which emitters can fire and which you cannot fire. So like Raman was talking about, if the emitter is right at your bifurcation, at the ostium or the parenchyma, you actually can turn it off by pressing the button, so that way the action doesn't happen here, and it still is ablating or still doing its radio frequency work at the other side. So that gives us a lot of flexibility of how you want to treat and which segments we can actually choose them. So here you can see those 4 emitters right there. Right now all 4 are active, so all are highlighted, and then depending on what Raman would decide, we make sure, say, okay, if all 4 want to fire versus 1 versus just 3 or any numbers you like for your convenience.
This would be all 4 for this one. So
Good.
we can go ahead.
All right, so just, I don't know if we can look at the monitor right there, which it comes with the console. I'm going to fire anyways, but it comes with a console which shows us both the heat energy as well as the impedance. So heat energy, there are certain cutoffs where if it exceeds those cutoffs, is the emitter automatically shuts off as a safety mechanism. So I don't know if you can see the monitor, but our number 2 just shut off, showing that the impedance was high. So when the impedance is high, meaning there's so much resistance developing in delivering that energy, it actually shuts off as a safety measure. So that's another marker. It goes on for almost a minute every cycle. And usually what we do is, if there is any change, we try to torque it or change it to give us a little better apposition. So here's the monitor you can see. So you can see number 3 is highlighted, and the same thing highlights on a control as well. It automatically becomes red, which means it's off.
Yeah.
So now Raman would know. Sorry, Raman.
Yeah, sorry. So 3 actually seems a little bit close to one of the bifurcation points. So if that turns off, I'm actually okay with that. It actually seems to be right at that point. So this would not be one that I would want to then resume and then do once again. So it's important to always do your freeze frame to see where exactly you are, because you don't want to burn the same segment more than once. But that distal most inferior branch we never really got to. So we would like to get that lower one, which you see.
Yeah, so what he's trying to do is, as he pulls back, he's trying to engage the other artery as well, so that way you don't have to go back in. So idea, like I talked about, the concept is going from distal to proximal.
Sorry, a little puff.
A little puff.
Good. So that's an inferior one feeding.
Can we go to the other lab for 1 minute and come back?
Sure.
Yeah. Okay. Yeah, for sure.
Okay.
Let's go turn off.
Three is
turn off 3. Yeah.
3 is off.
Yeah.
No,
guys.
Wait. 3 is off. Wait. Yeah. No. Yeah. Good. Ready?
4 is the same.
Yeah.
1 is going to be
Can
too
you
big.
just go to the other lab and...
Yeah, if we can go to room 2 so they can
But just to show you on the monitor how Raman controlled it, so we only selected electrode 1 and 2, and we didn't want to ablate the 3 and 4 because we had already done it. So that gives us, like I said, the good thing about it is the flexibility of doing segments, what we think we want to do, and not touching the segments we don't have to do or repeat it.
Yeah.
But yeah, you can go to the other lab and we can be back.
This is just obviously, as you go back, we're just going to keep on going. We're going to do the superior lobe, and then we're going to pull back into the main vessel and then get ready for the other side.
Now, how many seconds you have to give ablation? How many seconds?
Yeah, so the device itself is programmed to do 60 seconds per ablation cycle. Per the company, they believe that about 45 seconds, which is kind of what they had seen in vitro, really does result in adequate nervous ablation. So if you hit 45 seconds and then the device, the channel seems to turn off, that's okay. You've reached achieved your desired dose.
What is the maximum time of ablation time?
So there's no real maximum amount of ablation time. All you want to do is that you want to make sure that you don't ablate the same surface more than once. That's the most important part. Give it a puff.
The point here is actually we don't know what is the target point you are looking for, because you already say 135 by 80 BP or 140 by 60 BP. So what is the target you are looking for in this case?
In terms of what are we talking about? Like the patient's BP?
We have to see the BP reduction. We have to see the BP reduction. What is the BP? What you are looking for? What is the aim of your BP reduction in this case?
So peri-procedurally, that's a good question. Peri-procedurally, there's no real guidelines as far as what you're looking for in terms of hemodynamic shifts. What we've been seeing, and in our own data here is that there is, so you see this, before I answer that question, initially I was saying that I think that the superior branch was too small, and we do see that to be the case as the monitor itself is saying that it's reaching a high temperature. So since it is hitting a high temperature, that means that superior branch is too small. So now this the more proximal portion of that lower branch we have to now hit. So because we never really got that, and then we'll be able to continue. But now, so again, the device itself is not really, you don't have any clear markers during the procedure besides the device itself, which is saying that you have delivered adequate therapy, right? So you have hemodynamic shifts that happen in some patients that don't happen in others. But the question is, does that mean anything? It's hard to really say. Anecdotally, what I've been seeing is that patients who have a very pronounced drop in their blood pressure peri-procedurally, as in when the ablation is actually happening, at that time, I found that they actually have a more persistent reduction starting very, very early post-procedurally. Which is not always the case. Typically, we'll see the reduction of blood pressure being a somewhat slow process, maybe taking 4, 8, 10 weeks.
Actually, what we saw in your monitor is actually nearly 100 systolic BP or 102 systolic BP. So, do you that may be a point of stoppage, or what is the point of stoppage? Actually, what is that?
So again, the hemodynamic tracings that you're seeing on the monitor are falsely low because of the sedation that we are giving. The second thing is that the device itself is not creating any effect on the hemodynamic tracings. That could be interpreted, give it a little puff, that could be interpreted as an effective or ineffective therapy. It's just simply a part of, let's turn off 3. It's just what is happening in terms of its combination of the conscious sedation and a combination of what perhaps could be a direct comparison of the effectivity based off hemodynamic tracings. But again, as of right now, that data is not out there. I was just sharing personal experience where you do see peri-procedural decrease.
So the only thing is, like Raman talked about,
switch over to the other lab because you are only can do that. She is waiting. We cannot switch over.
Yeah.
You can switch over. Please switch over.
Okay. Could we show to room 2? Show the finals over there. Great. So that was a great case in room 2. We've finished the right. We did all of our ablations on the right side. We had a tiny bit of spasm, which is totally normal post-procedure. So we gave some nitro, and typically we wait until we finish the other side, and then we will take another picture afterwards. And this is the picture of the left. This one is a little bit more of a technical challenge, more just because of that 2 180-degree turns that happens in that middle lobe branch. The one that's feeding the inferior lobe, we're going to say that we're just not going to have to. Did we get 45 seconds?
Yeah, we did.
That we're not going to have to treat that because that, like the upper branch on the right side, was also too small.
So just to follow up on that conversation of how do you know it's success or not? I mean, right now, like I said, we do not go after the immediate drop in blood pressure because remember, the sympathetic drive also takes time to kick in and have those effects. So that's followed up clinically, but from a procedural perspective, the idea is to make sure wherever you're doing your ablations, the monitor shows you've done successful ablations, and at the same time, you want to make sure you've done all the segments. So it's purely based on covering all the segments and having a successful result with the monitor showing it's successful. And then me and Raman will follow up these patients in clinic, and you'll actually see effects kicking in as early. We've seen it in like a week when we see them back. Some people take longer, but it's not about what we see up here on the monitor is suggestive of success or not success.
Yeah.
So that's usually how it's.
I think it would be really, really great if there was some very clear data peri-procedurally to signify that there is an actual adequate denervation process that is happening. But as Vishal was saying, is that this is a process that is a neurohormonal process. So it's not something that can really have a immediate effect. Yes, go on.
Dr. Raman, we have run out of time because the other live case in Canada.
Of course. No. Well, thank you very much for having us. If there's, luckily there's really not, besides just the final pictures, we'll just be able to share with you guys later offline the rest of the, the blood pressure management for this patient. But again, thank you for having us.
Thank you.
Thank you.